most commonly tested disorders is autism spectrum disorder. And you need to know this disorder so that you can distinguish it from other disorders that look very similar. So core criteria include social interaction and communication deficits. So they're going to have trouble reciprocating socially and emotionally. They also can have this impaired nonverbal communication. Decreased eye contact is very common in people with autism spectrum disorder. They also have difficulties in developing, maintaining, and understanding relationships. They also tend to have restrictive, repetitive patterns. So this might be stereotyped motor mannerisms such as hand flapping or lining up toys. Inflexible adherence to routines or ritualized patterns. And hyper or hypoactivity to sensory input, such as lights, sounds, textures. They tend to be very overwhelmed by overwhelming sounds and disliking different textures, which can cause eating problems sometimes. As far as prognosis and treatment, best predictors of outcome is the level of intellectual functioning, because that can vary depending on where they are on the autism spectrum, and then language impairment severity as well. Management strategies include early intervention and special education, behavioral therapy, such as ABA therapy, and medication actually can be used. Low-dose atypical antipsychotics, such as risperidone, Abilify, can be used for irritability and aggression. Now, other neurodevelopmental disorders are frequently on the differential with autism spectrum. So let's talk about them so that you know how to recognize them and you know when to pick them. So there's the intellectual disability. And this is deficits in intellectual functioning, such as reasoning, and adaptive functioning, such as social practical interactions. The severity is based on adaptive functioning, what support is needed for these children, and not just IQ score. Diagnosis requires clinical assessment plus standardized testing, at least 2 standard deviations below the mean. Onset, it must occur during the developmental period. Now, you really need to know etiologies because these etiologies are frequently showing up on exams. So etiologies could be Down syndrome, Fragile X. It could be prenatal, such as the Tourette diseases, alcohol, perinatal. You need to know these for the exam. Global developmental delay. This is the diagnosis for children under the age of 5 when severity cannot be assessed reliably. Then you have the specific learning disorders. So these disorders are academic skills significantly below the age expectation. And these skills have to be in such a deficit that it interferes with daily life in school. Affected areas include reading, which is dyslexia, writing, or arithmetic, which is dyscalculia. It begins in school and it tends to worsen as demands increase. Treatment is systematic, individualized education tailored to the needs of that. Next, we are going to discuss tic disorders. So tics are sudden, rapid, recurrent, non-rhythmic motor movements or vocalizations. And these are often preceded by this uncomfortable sensation, temporarily suppressible until it's not. For Tourette's disorder, the criteria is multiple motor tics and at least one vocal tic, so it has to be both. Duration, the tics must persist for at least 1 year in order to have the diagnosis of Tourette's. Now, the onset must be before the age of 18 as well, and that's why it's a child psych disorder. Of note, highly comorbid conditions are OCD and ADHD. So what do we do for treatment of tic disorders? Behavioral is first line. Psychoeducation and habit reversal training, CBIT. You can use medications as well. So we do use alpha-2 agonists, guanfacine or clonidine, which are good for comorbid ADHD because they also treat for ADHD. Antipsychotics can also be used, risperidone, Abilify, and those are for severe impairing cases. And that's not because they're not as good as the alpha-2 agonists, it's because that antipsychotics have more side effects. That's why they're reserved for the severe impairing cases. Next, we are going to discuss elimination disorders. So enuresis, or bedwetting, is recurrent urination into clothes or bed. Criteria: it must occur at least 2 times per week for at least 3 consecutive months. And the child must be developmentally at least 5 years old. This is important to note because they like to see if you know this age cutoff, and they may present to you a child that's maybe 4 years old and they would not meet criteria for an elimination disorder. Treatment: behavioral, fluid restriction, and bedwetting alarms can be used. Desmopressin can also be used. It is the first-line medication and it's an ADH analog. Encopresis, or fecal incontinence, is another elimination disorder. It's recurrent defecation into inappropriate places. It occurs at least 1 time per month for at least 3 months. And the child must be developmentally at least 4 years old. Again, pay attention to the age. Etiology is often related to constipation and impaction with overflow incontinence. Treatment is bowel clean out, stool softeners, plus high fiber diet, and behavioral toileting routine. It's important to note that with these elimination disorders, you also want to rule out medical causes of the child either bedwetting or defecating in inappropriate places. Cover high-yield facts about ADHD in another video, and you can click on that on the right. Otherwise, stay tuned for part 2 of the child psych disorders. Good luck on your exam.